All right, guys. Today we're going to talk about NRP, Neonatal Resuscitation Program. We do not do this program in our course as of yet. It is something I would like to see changed. I would like to see us do it. It is pretty intense. And you can have the course and you don't have to pay for the card. You can just get the knowledge and they will go ahead and come down, and they usually I know some people at Erlang will come down and they'll teach the course and they'll talk about the course and they'll do a lot more hands-on stuff with neonatal resuscitations and the things that can go wrong, because up to this point we have talked about mom being pregnant and what can go wrong there, mom laboring and what can happen and go wrong during labor. But now we're going to talk about when you have two patients after baby is born, the things you need to look for in your assessment findings that you need to use. Don't forget your APGAR scale. That's going to help you. So you can APGAR score the baby at 1 minute and then at 5 minutes, and then hopefully everything goes well from there. And also if you've got mom as a patient as well. So we've talked about those things, but now we're going to get into how to deal with baby and how to treat baby if things are going wrong. In utero, remember, baby gets oxygen from mom, from the placenta. But once baby comes out, and the first real true pressure is taken off baby's thorax, things happen, things change, and baby now has to start taking in and breathing oxygen on their own. So they need to start getting oxygen in. There are signs and symptoms to look for that'll tell you that that's not going well. So as the baby kicks over and changes, usually baby, like we've talked about before, is usually getting, there's one big major artery going to the baby from mom, and then two veins coming back out. There is a couple things that are different with fetal blood flow. One of the things is that you'll look here, in fetal blood flow, there's an opening in the atria between the right and left atria. That's called the foramen ovale. So what's happening is from the placenta, blood is coming in the inferior vena cava, and oxygenated blood is now mixing. It's mixing. So now baby has a mixture of oxygenated and deoxygenated blood. Goes in the atria. Well, it doesn't all just go down to the right ventricle and go to the lungs. It actually kicks over and mixes, and it's over in the foramen ovale into the left ventricle and mixes with more oxygenated blood and then comes out. So this is kind of like a fail-safe to make sure that baby does indeed have that. Now, when you hear the phrase congenital heart defects, there are things that can go wrong. One of them being is that when baby's born, this over time slowly shuts down within the first, I believe, week of life. That'll close. You also see this right here, this arterial duct or ductus arteriosus. That actually will close. That'll shut down and close. And then they just have pulmonary circulation. So literally, you're bypassing pulmonary circulation as well. So those are pretty much the notable differences. And then these wind up all closing out. And these little things, when they close, these arteries and veins become ligaments. They close down and they just hold things in place. This will close down, and it comes the ligamentum arteriosum, and then they become umbilical ligaments and stuff like that. So they wind up becoming ligaments. They no longer flow blood anymore. They are just a holding position. So, but you can take advantage of the fact that when you cut the cord, if you need vascular access, you can still use it. We'll talk about that here in a minute. So baby's flow has got a lot of mixture, a lot of good oxygenated blood. So, but when baby comes out, those things are no longer in play because you've just cut the cord. So now baby needs to rely solely on breathing on its own and taking in its own oxygen. Here's some things that go wrong. Hypoxia is the big one. Hypoxia is going to be your driving force. Usually what's wrong with baby is hypoxia. And again, if there's a problem with tetralogy of flow and there's an issue there, that's going to be your key that things are going wrong and baby may need some support. So it happens. It's kind of like a 1 in 1,000 or 1 in 100,000 thing, but there are issues, and believe it or not, baby can have these repaired. Some can be repaired and moved. There's 4 or 5 different ones. I'm not really going to get into it and bombard you with that, but just realize that there could be a problem with circulation for baby, especially when you start taking these actions that we're going to talk about here, and they're not working. So remember we talked about meconium stating and basically can lead to the pneumonia. Hypotension, if there's a lot of bleeding and stuff like that, baby needs a little bit of fluid. We'll talk about that. I know you guys aren't there yet, but we're still going to talk about it. Birth asphyxia, which is basically it's suffocating without the oxygen. And the thing we talked about, like baby's head being on the umbilical cord or pressure being put on the umbilical cord. Also, we talked about the nuchal cords being wrapped around baby and how it might restrict blood flow to the baby, things of that nature. And there's some other things here, but really hypoxia and meconium staining are pretty much your big ones. Sepsis is a big key. If there's infection somewhere and baby winds up with the infection, baby can suffer from sepsis. So there's things to be looking for. If baby has distress in utero and it's delivered, it might need a little extra care. So if you have any of those problems, like the cord, there's a presentation of the cord, shoulder dystocia, any of those that we talked about in our last section, those can lead to hypoxia, hypotension, respiratory depression, apnea, baby not come out breathing. Will also lead to poor muscle tone. Again, your APGAR scoring is going to be what's going to clue you in. And you'll probably have a good idea. Most babies come out kind of flailing a little bit, and they're crying, and they got a good vigorous cry, and they're breathing, and their heart rate's up, and they look really nice and pink, and things are going great. It's when you start noticing those other things that are on the APGAR scale, that's when you need to clue you in that something's wrong. So when baby's born, I've already kind of mentioned it before. When baby's born, you're looking to warm the baby, warm it, and also have tactile stimulation. Basically, when you're rubbing baby down and you're trying to make baby dry, get all the amniotic fluid off baby, that's tactile stimulation. You're stimulating the baby because you're touching the baby. But if that doesn't work, there's a couple places you can use. You can't really sternal rub a baby, but you can do a heel flick. You can literally take and flick the bottom of the heel, and that aggravates baby to no end. And that kind of stimulation, kind of gently flick the heel, and that'll kind of get baby up and moving, and that tactile stimulation should make it more alert, and that should help it. Also, you're drying it, the tactile stimulation, and you're going to put it, not use the same wet blanket that you just dried baby with, but hopefully you've got another blanket. If not, that's okay. Keeping baby warm. Baby's warmth is key. That's another reason why I said put skin to skin. Let mom's warmth help warm baby and keep baby warm, and also make sure baby's wrapped in a blanket. Also turn the heat on in the back of your ambulance when you're having a baby. I don't care if you're sweating. If you've got a baby, the whole trick the key to this is keeping baby warm. So warm the baby, dry the baby, and tactile stimulation. That's what you should be looking for. And then try to run a quick APGAR in your head. We're assessing skin color. We talked about that they might be cyanotic in the extremities and pink in the core. They're basically their abdomen, their thorax, and the head. As long as they're pink, that's okay. That can be normal. And you're looking for a heart rate over 100. So hopefully babies, when they're born, 140, 180. Usually it'll spike up when they start crying and get mad, and it'll shoot up. Sometimes shoot up to like 180 to 200. And I know that seems excessive. That's not the norm. But for these guys, it is. Remember, they circulate a lot of blood really quickly because proportionally their bodies are bigger compared to the amount of blood they have. So to combat that and make it work, they have to pump faster. They've got to get blood circulating around to get oxygen and rid CO2 quicker. There's not enough volume there. So instead of having the volume, they go with speed. So over 100 beats a minute, that's fine. And even if you have some peripheral cyanosis in the hands or in the arms and the legs and the feet, that's okay. Especially when they're first born, that's okay. It's their body changing over and getting used to having to go ahead and get their own oxygen in and circulate it around themselves. All right, so we've already talked about it. Warm the baby. Make sure you clear the airway. The airway should be cleared, hopefully, if it's not an explosive delivery. It should be cleared, mouth, then nose. Remember, LMN, mouth before nose. So hopefully you're able to suction out baby when the head comes out of the vaginal cavity, and you're able to go ahead and suction that out. And then you can deliver down and out, get that anterior shoulder down and out. And then you can, once you have the mouth cleared, if you need to suction some more, go ahead, get it suctioned out. If you need a little bit of help, especially we're going to start talking about managing the airway, remember you may have to pad underneath the shoulders. Not a whole lot, but just enough. Their heads, Their heads for babies and children are proportionately bigger than the rest of their body compared to an adult. So the head is proportionally bigger to the body than it would be in the adult. So keep that in mind that you may have to pad shoulders. There is an algorithm. We're going to talk about that. The first thing is when you have a baby with a heart rate less than 100, and I'm talking about sustained heart rate less than 100. Baby comes out, may have a kind of a lower Apgar scale, heart rates below 100, but above 60. This is the key, between 60 and 100, which would technically be normal for an adult. That's kind of how you can remember that. 60 to 100 is normal, but for a baby, not normal. So they may need some ventilatory assistance. You can do some positive pressure ventilations. They make neonate or smaller bag valves. Remember, you're not looking to shove all of the volume in there. You're just looking to get good chest rise. Be very careful. These guys they're fragile. So if you blow a lung, you'll cause a pneumothorax. You don't want to do that. Just enough to get good chest rise and assist them and give them O2 supplement. I know I would probably hook up to, not thinking I'd probably do high flow O2. They say you don't have to here in this section. We'll talk about that when we get to it. But again, you want to do oxygen therapy, you can start with that. If they're breathing fine, they got a little cyanosis, and you're kind of concerned, you want to start with a little non-rebreather, that's fine. Fantastic. Go ahead and do that, and they're breathing fine. Maybe the heart rate's hovering around 100, and you just want to give them some supplemental oxygen before it drops below 100. Fantastic. Not a problem. But if it winds up being, it starts dropping under 100, and it's sustained at 100, and you still see it falling, you need to intervene. You need to go ahead and start doing maybe some positive pressure ventilations. If the heart rate falls below 60 and it's sustained under 60, you need to start CPR. I know that's up to this point. We've only done CPR on people who have no pulse. But if a baby is now at 60, you need to start CPR. And there's a technique, and I'm going to show you the technique to do infant CPR. Especially if you have two people, you're gonna bag. I know in your BLS it was like 15 to 2. 2 rescuer, 30 to 2, I think, on a single rescuer for pediatrics, but we're talking about babies here. We're talking about babies. We're going to do this with babies. Also, if you are having problems sustaining a newborn and you can get an ALS intercept, you can get a paramedic there, get them there. You may need to give some epi, and you might need to give some not some D50, but some D10. You can make D10. I'll show you guys how to do that too, to make D10. You may have to tube them. You may have to do them. And again, this is probably more than likely some sort of issue, as in maybe they aspirated meconium, or they have some sort of issue with the tetralogy of flow, like they've got some sort of congenital heart defect, and now you're going to have to try to manage this patient to get them to the care that they need. Again, we talked about epi, hypovolemia. We're going to kind of talk about that. I know it's kind of above where you're at right now, but I want you to keep it in the back of your mind so that it's there. Basically, you're going to the guiding factor for you is going to be kind of their respiratory rate. Remember, they breathe really fast. Also, babies are what's called obligate nose breathers. That means they keep their mouth closed and they breathe through their nose. So make sure their nose is clear. You may have to suction some more. That's not a problem. You may want to try suctioning right quick. See if you got all the gunk out. And see if they're able to breathe through the nose, and see if that fixes it, and put them on a little O2. Fantastic. Heart rate's hovering around 100, starts dropping and falling. All right, we're going to move to oxygen and positive pressure ventilation. And then if it drops below 60, you're going to start doing CPR. We just talked about the free flow oxygen. We're going to talk about the positive pressure ventilations. They do make little pediatric babies, neonate, infant-sized bags. Again, we're not looking to force everything from the bag into the patient. We're looking to just get good chest rise and fall. The best thing you could do is learn how to do a good mask seal. Remember your CE grip. And of course, with them being little and itty bitty, don't forget, pad the shoulders. Here they're not showing pad the shoulders. The head's so big that they didn't pad the shoulders. You're probably going to have to pad the shoulders. But remember, padding too much will hyperextend them, and then you're doing the same thing. You're closing their airway and making it slimmer. So just a little bit of padding will take care of it. The oxygen rate they said is 5 liters per minute. All right, so you won't probably find a setting of 5. You'll probably find a setting of 6. You're not wrong with 6. So Go ahead and start them on a little O2 if their heart rate's hovering around the low hundreds. And then if it starts falling, go ahead and do your positive pressure ventilation. And again, we're going to talk about CPR under 60. All right. This is kind of repeating the same thing, but they're talking about bagging. And if you look at the mask size. Now, that's, I think it might be an adult BVM that they're showing, but the mask size is different. Again, they're not going to cram all that in. You will harm and do barotrauma. You will bust and drop a lung, and they'll have a pneumothorax. And it may even tension. And I know you guys don't quite know that yet about those type of trauma. Again, that's shock trauma. I'm sorry we're doing this class before we do shock trauma, but there again, you can cause a pneumothorax. So also, if you've also seen the baby breathing, and it's kind of hard to show, but they'll have intercostal retractions, meaning that you can literally see their ribs when they breathe. They'll take a breath in, and you'll see them suck in, and you'll see their ribs. The muscle between the ribs is what's helping them breathe. Or at least they're using those muscles to help breathe. So you may see that nasal flaring, grunting. If they're that's going to cue you in that something's wrong. They're having a hard time breathing. So these are things that you need to look for. The nasal flaring is when they breathe through their nose. Remember, they're obligate nose breathers. They breathe through their nose. They're going to try to get their nostrils to just flare open. So keep that in mind. Sniffing position, pad underneath the shoulders. I know I'm kind of repeating myself, but there's a lot of repetition in here. If their heart rate drops below 60 or they're pulseless, that can happen as well. If you've got two rescuer, the best thing you do is your circle technique, and you're going to go ahead and do chest compressions like this. I know it's kind of hard to see in my hands, but these will go underneath baby's back. Two thumbs up in front, right at the sternum, and you'll use it like this. So there's a technique to that too. I'm not showing it, but basically the technique is with two people, and that is right there, right quick. That is a appropriate size BVM for the neonate. But it's 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. And usually the person performing the chest compressions will do that. And it's literally that quick. You're doing CPR and ventilations that quick. And the sole purpose is this person is to ventilate, this person is to count it off and do chest compressions. And it is, again, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. Now, again, 15 to 2 if you're by yourself. And it's harder by yourself. And remember, you are a team of two. If you're doing CPR on an infant, no one's there to drive you. Hopefully you'll have either fire or someone else coming to meet you. And I'm sure that if this call goes out, mom is laboring and has is baby's imminent delivery, or you get called out for that baby that's found not breathing, that's going to be the CPR technique you're going to be looking to do. Oh, there it is. They were talking about it right here. Adequate ventilation. Again, just good chest rise. Again, turn the heater on too. Don't forget, keep these babies warm. They don't want to be and don't like being cold. Vascular access. This is where you can do it. This is where they're showing that you can get it. Good luck. Good luck. It's going to be tough. You can do it. I've done it on little baby toddlers. I've not had to do it on an infant, thank God. Knock on wood. But you can also do IO access as well, which we'll do in your advanced class. In the event the baby's just born, you can use, and that's why I tell you to leave some room on the umbilical cord. When you cut the umbilical cord and you're looking at it face on, remember, there was, I believe, two veins coming back, one big artery going in from mom, but now those are reversed. Remember, the big artery was going into the inferior vena cava. Well, the umbilical cord's still there. You can cannulate that. Don't stick an IV needle down in there. Just take it off and slide one in. And look at it. It's kind of like a face. Feed the mouth. That's how you remember that. Feed the mouth. That's going to take you to the venous side of things, and it's going to get it so it'll circulate in and around in the event that you have to give D10 or epinephrine, which is above you. But if you can cannulate that and have it ready in case you have ALS intercept, you can say, hey, we cannulated that for you. Go, and I believe it's patent. We use a little bit of flush. And again, you're not looking to do a lot of volume in these kids either. They don't take much to get them to bounce back. So you can use that. Remember, you may have had to deliver the baby and you cut the cord and everything's fantastic, and then baby's not responding and the APGAR scores are low. You can still cannulate that for them. Apnea, they're saying it's very common delivered before 32 weeks. So if they are looking like they are preemie, you need to expect at delivery that you are going to have to be working this kid. So be prepared for that. Preemies, you're going to have to be thinking, oh God, I'm going to have to work these kids. And remember, they're calling preemies in this lesson 20 weeks to 36 weeks old. So those are considered preemies. So be prepared for that. And remember, I told you, about week 27, 28, the surfactant starts forming and they're able to keep their lungs open. They're saying 32 weeks. That's probably after some of the surfactants formed and they've got good working surfactant and they can breathe and they've been practicing breathing in utero. So be careful of that. But if that doesn't work, if you've got apnea or you got heart rate under 100, you're going to be looking to bag. Hypoxia will follow hypothermia. Again, keep them warm. They need to be warm. Very crucial. I know mom will be sweating and delivering, but like you need to have that back of that ambulance or in the area that you're delivering warm. And if you can't keep it warm, get ready to go ahead and put baby in blankets. And off the cuff, if you've got fresh newspapers, ones that haven't been used and touched by a lot of people, you've got a fresh newspaper there, that's the best thing. Newspaper will keep baby warm and real warm and insulated. So that's really good to have. They've got primary apnea and secondary apnea. I'm not really going to go too much into that. But basically, if baby has an apnea period and you get them breathing again and it looks fine and they start having a secondary period of apnea, that's when you need to really be worried. Bradycardia. Again, chest compressions under 60. I know I'm repeating myself, but hopefully you're getting the message. Heart rate under 60, bradycardia for a baby is 100 or less, in my opinion. That's what I've taught. They're saying 60 here. I'm saying it's going to be under 100. That's when you're going to start having the bradycardia. Baby should not be under 100, period, especially at being newborns and neonates. Hypoglycemia, you do need to check for a D-stick. Where you do it, you'll do it on the heel, the bottom of the foot. And again, they don't like the little bottom of their feet being touched. It's very sensitive to them, but that's what you're gonna do. You're gonna do a heel stick, and you'll check their blood glucose from there. You're gonna give them something called D10, and I'll show you how to make that when we get to the advanced portion of the EMT section, because I believe D50 is your drug. I'll show you how you can make D10. You probably want to check them. They usually in the hospital, they will do a heel stick on the baby just to make sure. Even if it's a little bit low, they may give a little bit of D10 just to help baby along to make sure that they got they got it. They say babies like to be warm and sweet. They like to have they keep an eye on the sugar, make sure baby is processing sugar okay on their own. Because remember, a lot of things were done by mom through the placenta. A lot of things were regulated through the placenta. But now you've got to go ahead and make sure that baby when baby kicks over and starts using their own heart to circulate oxygen, their own lungs, and things of that nature, you need to make sure that they're good. So warm and sweet. It's hard to get a blood pressure, but if they are still pale and they have weak peripheral pulses, remember, you're going to be checking brachial pulses on these kids. You can do a 10 milliliter per kg isotonic fluids. We'll talk about that when we get in there. Typically for an adult, it's 20. So for a baby, you're just going to cut it in half. And remember, these kids only probably weigh like 5 pounds, so maybe 10. So they might just need 100, and they don't need it slammed in all at once. You probably want to give it over a little bit of time. So we'll talk about that when we get there, but that's how you avoid hypovolemia. And that's it. That was short and sweet. Again, the keys to this are your heart rate, your APGAR score, their breathing rate, and the things that you need to do to facilitate that. Check a D-stick. And make sure there's no meconium staining or there's no issues with delivery. Sometimes babies just need a little help getting started. Like I said, my middle child, my youngest daughter, had a nuchal ×2. So when she came out, she wasn't breathing. They had to, back then I didn't know, but now I do. And I realized that they had to bag her and get her oxygen saturated up. They had to warm and dry her, and they kind of had to stimulate her. And it was about 30 seconds or so after she was born, after the cord was cut, probably about a minute, where there was no crying and screaming, because when baby comes out, you like to hear the crying and screaming, and oh, that's great. But if that's not happening, things are south, and you can't wait. The key to this is don't wait. If it looks bad and it looks like it's bad, the longer you wait, the worse it gets. These kids are kind of fragile. You're going to have to go ahead and intervene quickly. All right, guys, that's it. Sorry for the delay on the chapters and getting them out and all these presentations, but I had to break it up because it's a lot of information. And I'll talk to you guys soon.